to palpate the masseter muscle, there's a few things we can do, but we know that the masseter muscle is one of the big players in mastication. So what I want to do is go right below the patient's zygomatic arch, just right here. And then I ask the patient basically just to clench down. And we'll feel the muscle belly fire up right in here. So again, basically to get that muscle belly to fire, we just palpate that area and then we ask the patient to clench down. So another test we can use for looking for thoracic outlet syndrome is the costoclavicular test. So similar to the Addison test, we're going to bring the patient into some little bit of shoulder abduction, external rotation, and extension. And what we do is just palpate his radial pulse. And what we do is just hold him in this position. And what we're really trying to do is just close off that or impinge the thoracic outlet. And a positive test would be a diminished radial pulse. And if his pulse stays the same, then that would be a negative test. So to palpate the temporalis muscle, it's kind of similar to how we do the masseter, but we know that the temporalis muscle is in the temporal region of the skull. So I'm going to come just right here, and then I ask the patient, can he just bite down again or clench down? And then we just so slightly feel that muscle pop up, and that was how we would palpate that muscle. So for general cervical distraction, what I'm doing is I'm just testing for the ligamentous, just general motion. So what I'm going to do is just come under right into the occiput. And what I'm going to do is just apply just some slight distraction right here. Just feeling for that motion. I can come just like this. And if I want to do more AA, what I'm going to do is now I'm going to look for C2. So I'm just going to grab C2 right here. Basically what I'm going to do is bring him into a little bit of flexion. And what I'm going to do is just bring him into flexion and then drag on from C2 and bring him into that distraction. And then that would be the cervical distraction, general and AA. So the Wright test is, again, another test that we can look for if we're suspecting there might be a possible thoracic outlet syndrome. So what I'm going to do is just have my patient abduct his arm all the way up to 180 degrees as far as he can go. I'm going to then bring him into some external rotation, and I'm just going to palpate the radial pulse here. And after holding this for just a few seconds, or just for a little bit of time, if the pulse starts to fade away or begins to diminish, that would be a positive test for potential thoracic outlet syndrome. And if it doesn't, that'd be a negative test. So the Roos test is another test that's looking for maybe a thoracic outlet syndrome. So basically what I'm going to do is I'm going to instruct my patient to put his arms up almost like he's making a field goal, about a 90-degree angle, just like that. The mask going to do is just slowly open and close his hands. And he doesn't have to do this too fast or too slow, just a pace that's comfortable for him. But what I'm going to ask him to do is do this for 3 minutes straight. And if he starts to complain of any maybe numbness or tingling in the hands or the arms, that could be indicative of a possible neurologic thoracic outlet syndrome issue. Or if I notice some blanching in his hands or maybe complain that they were getting cold or something of that sort, that could be indicative of a vascular thoracic outlet syndrome issue. And if neither of those things happen by the end of 3 minutes, that'd be a negative test. So if our patient comes in, they're complaining of jaw pain or something like that, and we notice that their resting position of their mouth might be a little out of line, it might be causing some pain or discomfort, what we do is educate our patient how to be in the correct position of tongue resting. So basically what I'm going to do is educate my patient that your tongue needs to be sitting in a position right before they're saying the word no. So right when you feel that tongue right behind the top of your teeth, behind your teeth right there, so that no sound. And then you want your teeth not clenched but slightly open. You can have your lips closed, you don't have to have your lips open, but just like that. And what I can do is I can even remind my patient maybe every 15 or 20 minutes, just have a timer go off on your phone just to remind them to get into that position, and eventually it should become a habit. So another part of the neuro screen that we can do is looking for peripheral nerve. So if we're trying to determine if this is maybe a nerve root problem versus a peripheral nerve, we can do some reflexes. So first, I can do the brachioradialis, the biceps reflex, or the tricep reflex, as well as even the TMJ. So we know that the brachioradialis reflex is C5, C6. So basically what I'm going to do is come, it's hard to see the camera here, but I'm going to come right here and basically just ask my patient, put your hand here, relax, and push up against me. Just feel that tendon runs. All right, relax. Look away from me, please. All right. And then next for C6, the biceps, I'm going to come just right here completely hold his arm, just passively, just let it loose. We'll tap right here at the biceps tendon. Nice. And then we're gonna right here for C7. We're gonna ask the patient to look away, flex your trap, or not flex your trap, push your arm against me. Perfect. Relax. Wow. All right, and then last one, we'll do the TMJ reflex. So basically, use my index finger right here on his jaw, so slightly open your jaw. And I'm just gonna tap right here. So for that one specifically, we should see a slight closure of the jaw. Anything more than that, it will be an abnormal sign. But again, these are all used for looking when we're trying to determine if it would be a peripheral nerve versus a nerve root. So similar to measuring opening and closing of the TMJ, now we're gonna do this lateral deviation. So basically I'm gonna do the same thing. I'm gonna use just a straight edge. You can use a goniometer, but we're gonna make sure everything's clean and whatnot. So we're gonna measure between the indent of the top teeth and the indent of the bottom teeth. So we'll go each way. So first we'll start in the middle, and then we'll ask our patient to laterally deviate, so make his chin go to one side. So we're gonna start in the middle and then go one way. All right. And now come back to the middle and then go the other way. And then that is how you'd measure lateral deviation for the TMJ. So the passive shoulder girdle raise test is another test looking at if we're looking for thoracic outlet syndrome. So basically what I'm going to do is I'm going to instruct my patient to just hold, put their arms on each shoulder just like this. And then what I'm going to do is come behind the patient and basically just grab under his elbows. And I'm going to just apply some passive, or going to passively raise him for about 30 seconds. And so when those 30 seconds were up, if the patient's symptoms were to be relieved, then that'd be a positive test. But we have to remember this test that the patient has to be presenting with symptoms, because this is a symptom relieving test. So in order for us to do this test, the patient need to come in with those symptoms, and if we did this test and his symptoms were relieved, that would be a positive test. So after you do your active and passive range of motion at the cervical spine, we can then move into some isometric testing. So to make sure that we're doing all the positions, so basically what we'll start with flexion, and before I do, I'm gonna bring him just in some slight flexion. And then I'm just gonna push through or hold his forehead, and I'm gonna ask him if that's okay and everything. So just push your forehead into me. All right, we're going to a little bit of extension. Same thing, push into me. All right, and then we're gonna do side bending next. So we're gonna side bend this way, so just a little bit this way. Wait, turn this way just a little bit, there you go. Apply that same pressure. Same thing on the other side. And then for rotation, we'll do the same thing. So we'll turn him this way a little bit and then turn to your right. Okay, now turn this way, turn to your left. And that would be the cervical spine isometric testing. So when we're doing some muscle length testing to try to determine maybe if there's some tightness, or if that tightness could be contributing to some of their patient's pain, we can do this for the upper traps. So for the upper traps, I'm going to ask the patient to flex his head, or I'm going to flex his head for him. Then we're going to side bend away and rotate towards. So I'm now going to hold his head in this position, and I'm just going to depress the scapula with his hand at his side. And that is how you test the muscle length for the upper traps. When doing a muscle length test for the Levator scapula, it's very similar. So I'm going to bring him into flexion. We're going to side bend and rotate away. And again, I'm going just to depress that scapula to provide that stretch. And that is how you would muscle length test the Levator scapulae. So when looking at the range of motion for TMJ, we're really looking at two things. So we want to do an observational one first, and then we're going to do an objective measurement. So when we're looking for the mouth opening, we're really looking for either for it to be normal, for symmetrical opening and closing, or there could be an S curve or a C curve. So an S curve is going to be where they start that opening, they're going to kind of vary left to right possibly, but by the end they're going to come back to normal. So it'll be a straight line by the end, but just the way they get there is kind of off. A C curve will be, they could kind of vary it to one side, but then they're going to stay to that side. So they won't come back to midline. So to measure this, I'll be using, you're going to use like a ruler, but make sure everything's clean. You usually want to have gloves, but we don't have gloves. So basically, I'm not going to put this in his mouth, but you're going to want to measure from the top of the bottom, or the bottom of the top teeth to the top of the bottom teeth. and you want to measure in millimeters. So basically just have him open his mouth in a controlled manner. And we're just going to use this ruler just to make sure we're right there. And that is how you would measure range of motion for the TMJ. So to palpate medial and lateral pterygoid, we know that they have to be palpated intraorally, but I have to make sure the patient's okay with this, so we have clean gloves, everything, and make sure the patient's okay with it. But to palpate the lateral pterygoid, I want to go up to the top of the mouth and then make them go to the same side excursion. So if I'm palpating his right lateral pterygoid, I'm going to ask the patient to open his mouth, and I'm going to come up just on the top of his mouth right here. And then I'm going to ask him to move his chin that way. And then you can feel lateral pterygoid pop out right there. Now, if I want to find the medial pterygoid, I'm going to go to the bottom of the mandible over here and just palpate around the inside to that side right there. And then I'm going to ask the patient to go to that side. All right, one more time. And then you'll feel that pop out. And that is how you palpate medial and lateral pterygoids. So the cervical flexion-rotation test is a test that we're using when we're looking at upper cervical mobility. So basically what I'm going to do is just passively bring his head into just about full flexion. I'm just going to ask the patient just to basically just let his head loose, and then I'm going to let it fall in my hands. So when I have him in this position, I'm going to rotate him all the way this way. And then come back to neutral, and then go the other way. And this test is really useful for patients that experience cervicogenic headaches. So really what we're doing here is looking for any asymmetry. So the patient should be able to get about 45 degrees each way, and if there is any asymmetry greater than 10 degrees towards each side, that would be a positive test. So the deep neck flexor endurance test is a test similar to the cranio-cervical flexion test, but the clinometrics are not as good. But basically what we want to do is we're just testing those deep neck flexors, like the name implies. But what we'll do is just passively lift the patient's head, ask him to do a chin tuck, go into a forward traction, and I'm just going to lift his head off about one inch off the table. And the goal of this is for him to be able to hold it for at least 10 seconds without hitting the table. So for this test purpose, I will not make him do the full 10 seconds. If he was not, you can just relax now. If he was not able to hold that for 10 seconds, or his head would come down and hit my hands, that would be a positive test. So to muscle link test the scalenes, there's three portions of scalene. You have the middle, anterior, or middle, posterior, and anterior. So to test the middle portion, we can have the patient do this themselves. All I'm going to do is, if he's testing his right scalenes, I'm going to have him put his hand just like this on his head and pull directly away, just like that. Let's say more medial right here, just like that. And then if he needed more stretch, he could hold onto a table or a chair or something like that. Now for the posterior scalenes, what he's going to do is, if he's testing his right side, he's going to look to his left armpit and pull down from right here, just like that, and that would be the posterior. Now for the anterior, it's the same way, so he's going to do his hand just like he did, just like this, but he's now going to look away, and that is how he would test the anterior scalenes. So to muscle link test for the sternocleidomastoid, I have the patient in some extension. And then what I'm going to do is just going to side bend and rotate towards. And I'm going to just hold his head here, and I'm just going to depress the sternum. And that's how you would test the sternocleidomastoid. So the cranio-cervical flexion test is a test that we can use when we're looking to assess the deep neck flexor muscles. So we have a blood pressure cuff here, but generally you would use a more specialized cuff for this. But what we do is we're going to first inflate it to about 20 degrees or 20 millimeters of mercury. And then we're going to have him do a chin nod, take it to 22, and we're going to hold that for 10 seconds. Now for this video purpose, I'm not going to go through the entire process, but if I had a real patient here, we would inflate the cuff to 20 millimeters of mercury, then he would do a chin nod to 24 or 22, then we'd take a break to 24, take a break to 26, all the way to 28, while still at that 20 millimeters of mercury. But for this point, we're just going to pump it up to 20 millimeters of mercury and then have him chin nod and hold at that 26 millimeters of mercury mark. So I'm going to pump it up to 20 degrees. Okay, so I'm going to hold it there, and I'm just going to let him hold this so he can see where he's at. So I'm then going to ask him to do a chin nod, like he's doing a double chin. Perfect, he's right 26. So we're asking him to hold that for 10 seconds, but for this video purposes, we're just going to cut the time short. All right, you can put it down. Now, if he was not able to hold at least at 26 for 10 seconds, that would be a positive test for the cranio-cervical flexion test. So another test we can use if we're looking for some upper cervical instability is the AA transverse shear test. So basically what I'm gonna do is gonna go to below the occiput and find the transverse process of C2. And basically what I'm gonna do is just use the medial border of my index finger right here on that C2 transverse process. I'm just gonna apply a transverse shear. And for that to be a positive test, I might feel like a clunk or those symptoms like nystagmus, dizziness, lip paresthesia, or double vision. And if none of those things happen, it'd be a negative test. So these next two tests are going to be the alar ligament rotational test, stress test, and the lateral alar ligament stress test. And what these are for is to just basically see if there's a ligamentous issue with the alar ligament. So what I'm going to do is grab or palpate the C2 spinous process. I'm going to use a pincer grip to grab that. And basically for the rotational test, I should be able to turn his head, and at about 30 degrees-ish, I should start feeling that the spinous process move. And if it doesn't move, then that would be a positive test for the rotational test. Now the lateral stress test for the alar ligament, I'm going to do the same thing. I'm going to use that pincer grip at C2. I'm going to just come into a lateral side bend. And relatively quick, I should feel movement of that spinous process. And if I did not feel movement of the spinous process, that'd be a positive test. But due to the anatomy of the alar ligament, moving in these directions should cause the spinous process to move. And if it does not, that would be a positive test. So the anterior shear test is a test that is looking for upper cervical ligamentous instability. So I'm going to do is have my patient lie supine, and then I'm going to go under his head just below the occiput and find the posterior arch of C1. And what I'm going to do is just apply an anterior shear. And a positive test would be like reproducing symptoms such as nystagmus, blurred or double vision, lip paresthesia, or dizziness, or I feel like a clunk. And this test can also be done all the way down to T1. So the Jackson's compression test is another test that can be used if our patient's having some of those neurologic symptoms. So as opposed to the Spurling's test, this one is going to involve rotation. So if our patient's having radicular symptoms on his right leg or his right arm, we're going to have him look all the way to the left as far as he can. Okay. And then we're going to just apply some compression straight downwards. And then we're going to have our patient look to the right side. We're going to have that same compression. And now for this to be a positive test, the symptoms would have to increase more when he looked to the right, and they would actually have to happen again. And if no symptoms happened at all, then it'd be a negative test. So the sharp purser test is a test that is looking directly at the transverse ligament stability. So if we're suspecting that might have some integrity issues, so what I'm gonna do is first let my patient know to be palpating his neck area. So what I'm doing is I'm looking for the spinous process of C2. So what I'm doing is just use like a pincer grip, grab that, and I'm gonna hold his head right here while continuing to apply pressure right here, holding that spinous process. What I'm then going to do is apply a posterior force while bringing him into a little bit of flexion. And if that was a positive test, that would reproduce some of those upper cervical symptoms like dizziness, double vision, or nystagmus, or lip paresthesia. So a very key aspect when doing the cervical examination and evaluation is looking at myotomes. So we have to remember when we're looking at myotomes, we want to always make sure that we test the myotomes in a shortened position. And what we're looking for is a fatiguing weakness, which means that we want to hold that position for about 10 seconds to look for that fatiguing weakness. So we can start with C1. Now we want to make sure that we do these on both sides to get an accurate testing, but for this purpose I'm just going to be doing the left side. So we want to first, for cervical flexion, we're going to bring him into some flexion, so it's in that short position. And for this purpose, I'm not going to be holding for the full 10 seconds, just for the video. So I'm going to hold just like this. All right, now C2 would be side bending, so we'll side bend to this side, and we'll do just like this. C3 would be rotation, so then we'll rotate this way. C4 would be that shoulder elevation, so we're just like this, and come behind him here. All right. Now C5 is going to be external rotation as well as shoulder abduction, so again we'll do this side. So come here, just apply that downward force. And then for external rotation, we're just going to bring him into external rotation. We're going to support here. And we can also support here. Now C6 is going to be biceps for elbow flexion, wrist extension, as well as internal rotation. So we'll be using this bicep here. Again, we're going to bring that to that shortened position. Again, hold. Then we can do wrist extension as well. And then lastly, we could do shoulder internal rotation. So bring him into internal rotation. C7 is going to be tricep extension. So we'll bring him into that extension, that tricep position. Again, we'll make sure it's in that short position, so allow the triceps to not be on too much stretch here. And then C7 is also wrist flexion. So bring him into wrist flexion. Now C8 is going to be thumb extension. So we'll just bring him into that extension here. Just apply pressure here. And then lastly, T1 is going to be finger abduction and adduction. So spread your fingers like this. And first we're going to just bring his fingers together. So you're going to, okay, wait. So what I want you to do is don't let me bring your fingers together. All right? Now do your fingers like this and don't let me pull them apart. And that would be the myotome testing for C1 through T1. And again, we want to make sure that we're holding the position for about 10 seconds and then looking for that fatiguing weakness. So the Spurling's compression test is a test that is going to bring on the patient's symptoms. So patients might not like it, but if they're complaining of some radiculopathy or something like that and they come to our clinic, we can do this to try to reproduce those symptoms. So what we first do is we want to make the patient lateral bend away from the affected side. So if his right side is the affected side, we're going to have him lean to the right or the left. We're just going to apply some just slight pressure onto the head, downward pressure. All right, and then we're going to have him lean towards his right side. Same thing. And now if that was to not reproduce those symptoms, then we could bring him into a little cervical flexion and also the same thing into that lateral side bend and apply that pressure as well. And then we can do the same thing, that cervical flexion, side bend to the right. And then lastly, we want to be careful with this, but we can bring him into a little bit of cervical extension, not too much, and then side bend that way. Make sure we don't apply too much pressure to cause any issues. And same thing this way. And then, so if any of those reproduce the patient's symptoms of like numbness, tingling, or radiculopathy, that would be a positive test. And if it does not, that would be a negative. So the C-spine distraction test is a test that we can use if our patient comes in and they're symptomatic, so they're having maybe some radicular symptoms or numbness and tingling going down the arms. And basically this test should, if this is their problem, should help relieve some of those symptoms. So I'm going to do is just use the palms of my hand and then come just under the occiput. And basically what I'm going to do is just apply that distraction force upwards. And then I can hold this for up to 30 seconds. And then a positive test would be his symptoms were relieved, and a negative test means that his symptoms weren't relieved. But this test can also be done for up to 30 seconds, and it's important that we always slowly bring the head back down. So the shoulder abduction test is a test that is something else that can help kind of relieve these neurologic symptoms. So oftentimes, if a patient is coming in and complaining of neurologic problems, if it's coming from C4, C5 nerve roots, this could help. So what we do is ask the patient just basically to put their hand on top of their head, and if doing so relieves their symptoms. So if they currently had their symptoms when they walked in and then they did this, and then it helped relieve those symptoms, that would be a positive test. But oftentimes through maybe your questioning at the beginning or your subjective history, that they might say that it just feels comfortable to sit in this position, or they may even sleep with their arm above their head. So a upper cervical or upper quarter neurologic screen that we can do is the brachial plexus compression test. So basically what I'm going to do here is, we know the brachial plexus runs kind of between the sternocleidomastoid and the upper trap. So I'm going to go to that area, and I'm just going to ask the patient to look to the left, and I just feel where that fires. Alright, so what I'm going to do is come in here just posterior to the clavicle, and I'm just going to apply a compressive force. I'm just going to hold that just for a little bit, and a positive test would be reproduction of those paresthesia or pain, and if it does not reproduce those symptoms, it would be a negative test. When we're looking at our patient that might be having some neurological symptoms in the upper extremity, this is something we can do to try and determine if it's maybe a peripheral nerve issue versus a nerve root. Also, it can be used to determine, well, this is the median upper limb tension test, so we can determine if it's the median nerve. We can do an upper limb tension test or a radial nerve upper limb tension test. So what I'm going to do is first gonna bring our patient into some shoulder depression, and then I'm going to bring him into some abduction, and then I will then bring him into some supination, and then bring him into external rotation, wrist extension, and then I will then bring him into some elbow extension towards the end. And so for this to be a positive test, that would reproduce those symptoms. And then we also could, if it was not reproducing symptoms to the level that we think that it might be, we could also have him bring his right ear to his right shoulder and then repeat the test again. So similar to the median upper limb tension test, or median nerve upper limb tension test, we're really trying to bring on the patient's symptoms, and we're using this in a time where we're trying to figure out, is this a peripheral nerve or a nerve root issue? So basically what I'm going to do is stand right here. I'm going to again bring his shoulder into some depression, but this time I'm going to ask him to basically, hold your hand here, basically just bring his thumb like this. So hold your thumb just like this for me. And then I'm going to bring him into a little bit of abduction, but not until, right before 90. And then we're going to ask him just to go into some pronation, some wrist flexion, and then we're going to bring him into extension, elbow extension. And to sensitize this more, if he wasn't feeling, or he wasn't getting those symptoms be brought on, we can ask him to bring his right ear to his right shoulder and then redo the test. And if that test were to reproduce the patient's symptoms, it'd be a positive test. So the last test is kind of in that upper limb tension test cluster is the upper limb tension test for the ulnar nerve. So like the other tests I'm going to do is just bring the patient into some depression. And then I'm going to bring his shoulder in abduction, while basically just bringing his fingers to his ear. And already that kind of lights up, so we would know that that'd be a positive test. And again, this test is for trying to figure out if it's a nerve root versus a peripheral nerve issue. And this would actually be a positive test because the symptoms were brought on by doing this movement. If the symptoms were not brought on by doing that movement, I can sensitize it even more by asking the patient to bring his right ear to his right shoulder and then performing the test again. So the Lermite sign test is a test that we're looking to see if there might be an upper motor neuron lesion such as a cervical myelopathy. Basically what I have to do is, basically what I have the patient do is sit in a long sit. This would be similar to the slump test, but I'm going to ask the patient just to go into a slouch posture And what I'm now going to do is going to passively raise this leg. So for a positive test, the patient would feel maybe like an electric shock running down the leg. If he did not feel that or was not reproductive of that, that'd be a negative test. So one of the first vascular clearing tests we do is called the Haughton's test. And what we do is have my patient hold his hands out just like this, and we're going to have him close his eyes. And we want to have him hold this position about 10 to 30 seconds. And now if he was to start having some wobbly issues or he couldn't hold it straight, that would be a non-vascular issue. We can use sit them back down. Now next, I would have my patient hold his arms out again, but I'm going to have him close his eyes, turn his head to the left, and try to look back. And at this point, we're having some extension and rotation, and we're able to kind of close off the arteries on that side. So if he was to maybe have his hands move like this, that might be indicative of a vascular issue. The vertebral artery quadrant test is a test that you really need to do if you're doing anything like cervical mobilizations or manipulations, just to try to help kind of clear the area before doing it. So what I'm going to do is kind of bring my patient into some extension. So have him come off the plank, extension, side bend, and rotate this way. We're gonna hold it there for about 30 seconds. We're gonna make sure we keep his eyes open because we're looking for a nystagmus or complaints of double vision, anything like that. And again, we would hold that for 30 seconds, and you can sit back up. And if any of those occurred in that time period, that would be a positive test. If they did not, it'd be a negative. That we can just look at basically maybe if there's some first rib involvement or maybe there could be some asymmetry causing some issues is the first rib mobility test. So what I'm going to do is I'm going to come in and palpate the first rib so I know it's just under or just posterior to the clavicle. I feel that right there, and I'm going to have him take a deep breath in. So I should feel, or it is symmetrical, but I can have him side bend to the right, so bring your right ear to your right shoulder. And I should feel it raise on my left side, which it does, and I'll go to the other side. And I should feel the first rib raise on the right side. So again, this test is just looking for symmetry of the first rib. So the Adson's vascular test is a test that is in that thoracic outlet syndrome group of tests. So basically what I'm going to do is have my patient grab his arm. I'm going to look for his radial pulse. Okay? And then what I'm going to do is going to bring him into some abduction all the way to extension. We continue to have that pulse. Just in some slight shoulder extension. Now what I'm going to do is have him look at me and then take a deep breath in and hold it. Alright, and if that were to, his pulse were to be diminished, that would be considered a positive test for the Adson's vascular test.